So good morning, everybody. Welcome to Spine Grand Rounds. It's a small than usual audience because our Orthopedic Academy is going on in Chicago, so I apologize for the absence of many of our orthopedic colleagues. Some of our others are operating already since it was an emergency tonight. It's my distinct pleasure to welcome you here to the Spine Grand Rounds today with a distinguished visitor from the UK. Mr. Alexzander Montgomery is from London, from the Barts and Royal London Hospital. And he's going to talk about something that is very near and dear to our heart, the spine fusion topic. Just as a matter of background, Mr. Montgomery went to medical school in Glasgow, Glasgow University, 94 to 99, and received the Order of Merit from that school. He also was awarded the Purcell Prize from Wellington College, which he attended from 88 to 1993. His orthopedic training is one that literally brought him to every single major hospital around the UK. And just to mention a couple, Addenbrooke's Hospital in Cambridge, our neurosurgical colleagues will be very happy to hear that. Mr. Robert Crawford and Mr. Alan Coquard, Professor Alan Coquard, who lives in this very spot here a couple of years ago, was one of the teachers as well at the National Hospital for and Neurosurgery in London. He worked at the Royal Berkshire Hospital, Stanmore Hospital, Barts and London Hospital, and the Great Ormond Street Hospital in London, with a very rich and widespread orthopedic and spinal education. The spine fellowship took him to Auckland, New Zealand, where I worked with Peter Robertson, who also stood in this very spot here a couple of years ago. And he really has picked up a lot of very great research projects, and his zeal for investigation has really brought a couple of very cool projects forth, such as influence of ligamentum flavum hypertrophy and spinal stenosis, topping off for long level fusions, spinal cord monitoring and trauma, which in some countries is not widespread yet, and fusion stabilization and facet screws are some of the topics that he's presented. Today's topic, as I alluded to before, and as you probably can see for yourself, is one which incites a great deal of debate, especially in this state. We obviously live in a very adversarial legal climate here, and the basic premise of our legal system is one to find fault and then really through lengthy tribulations go towards trying to identify how much blame there is to be put on an individual. What if in an ideal world we went snap and we would not have anybody to blame, but we basically took the premise of saying, what if we just have to figure out how to resolve the situation as fast as possible? And without stealing any more thunder, it's my distinct pleasure to invite you here.
Very much.
Thanks for being here.
Yeah. Thanks very much, and thanks for inviting me to come and speak. So, it's about spinal fusion, specifically lumbar spinal fusion and compensation systems. So, is it really deleterious? Does it really affect their outcome? I'm from, as Dr. Chapman mentioned, I'm from Barts in the Royal London Hospital, which has 6 main sites, but the 2 main sites are Bang Centre in the financial district, and also in stark contrast in East London for the second site. So I have no to this. In fact, it's quite the opposite. I'm sure many of the commercial companies are gunning for me. Peter Robertson was the senior author. He's the Kiwi who supported this study. John Cunningham is a Ateneo consultant spinal surgeon in Melbourne. He supported me with part of this study as well. It's gone off. Let's try this. Oh, cool. So I may as well talk about. So what I'm going to basically talk about is a little bit about where I've come from in terms of the hospital that I'm in. Like I said, we have 2 main sites. The one site is, in fact, in Europe. It's one of the oldest, if not the oldest, in the world, and it's really in the centre of London. The second site is the complete opposite. It's the newest hospital in Europe. It was only opened last year, about 9 months ago, and financial district where it has a different type of population. It's in East London, which has a massive immigrant population and a different kind of patient dealing with. I'm also going to talk a bit about the background behind compensation systems and how I came to this study. And then the first part of the study is a systematic review of the literature on outcomes following outcomes following lumbar fusion. And the second part is the long-term outcomes of lumbar fusion in a system which is no fault, a no blame, a non-adversarial, non-taught system. Still not working. Might need your help again. So the first bit is really about Bartholomew's Hospital. It was built in 1123, and it was linked to the monasteries at that point. If I just show you use this.
Yeah,
Okay.
just use
Okay.
the mouse.
We all know where London is, I think. There's Germany, France. So London's right at the bottom. It's a financial epicenter of England. And because of its location, we do get far more immigrant population in that part of the country as opposed to up in Scotland, where people travel through Europe. So London has a big immigrant population, and a lot of them just sneak through. So you don't really, it's not like the US where you're on the other side of the pond and you have to fly to get there. You can pretty much swim across there and sneak in. So half the time we don't know who's there. I don't know if many of you have been to London. I think most of you probably have. It's a city steeped in history that has, been dictated mainly by the royal family and their history. Well, what really drives London now is it's the modern part of London. It sits in its history, but really we're about the modern drive. The city that really enjoys its festivals, any festival, and London is out. Any sporting event, everyone is out. It loves its festivals. And if you haven't been to London, well, you can't get bored in London. The nightlife is really knows no bounds over there. So St Bartholomew's, 1123, was opened by Henry I. And then because of some problem with the monasteries, they closed it at the time. And that's a bit of a long story. In fact, there's whole books on that episode. But Henry VIII reopened it again, and he made it his own hospital. And some say he only opened it because he was worried about his own health. Like I said, it's bang in the centre of the city, and it's right next to the oldest market in the UK, a butcher's market, which is still open now. So when you're walking towards St Bartholomew's, you have to actually walk through the market with all these guys chopping, beef and lamb and everything like that. It's got statues and paintings all over the place, some very rare paintings. That's our great hall where visitors come and give their talks. It's got 17th century paintings in it. So the first official, it had doctors there from the 12th century, but first physician was appointed in 1567. The first really famous person, he wasn't a surgeon, was who discovered the circulation in the blood. And some of the predecessors that worked in the same department as me, some of you would have heard of Percival Pott, as in pot fracture. In those days, TB was rife for different reasons. Basically because they didn't have any medication for it, didn't have a vaccination for it. Little did he know that the department he helped set up would be, we have the biggest TB population in the Western world right now, and it's in his department for completely different reasons because of the migrant population. Also James Paget, who was there in 1835. Many would have heard of Paget's disease. He also described problems with the mammary glands as well. He was extremely studious, probably the most hardworking of all our predecessors. He spoke about 5 languages in order that he could understand other people's research. Elizabeth Blackwell, you may have heard of. She's actually American, qualified in the States. She became the first doctor in the States to qualify. She became the first woman doctor in the UK, and she was also the doctor to King Charles. And John Abernathy opened the first medical school in Europe, and that was at St Bartholomew's. So that's the oldest building. It's in the centre of town. In stark contrast, the New Royal London couldn't be more different from St Bartholomew's. It's brand new. It opened last year. It cost £2.5 billion $2.5 billion to build. It's a level 1 trauma centre. It serves a population of around 2 million locally, and we serve the whole of Southeast England. I showed you on the map in terms of major trauma. It's apparently now the largest and newest hospital in London, and in stark contrast to the meat market that you saw there. You're probably wondering why I'm in Bangladesh, but actually, as you come out of the tube station, the underground station, that's what you get. It's completely immigrant population. We have virtually no local people. So vitamin D deficiency, TB, we even get malaria, sickle cell, the whole lot. That's the basis of our practice. And as well as that, we get the helicopter flying in about 1,500 times a year. So we keep ourselves pretty busy there. And its history goes back quite a way. It's 1740 it first opened. That's actually what it looked like. It did keep the Elephant Man in there. And then it modernized itself to what it looked like before. And then now that's all, in fact, on the same site, those three pictures. So those are the two places, really, that I'm working from. So the basis of this study came from, and they have a no-fault compensation system. Now, New Zealand is known for its Maori population. They first inhabited it before, the same old culprits, the Brits, came along and, created a whole bunch of trouble. It's very like Seattle, actually. In fact, it's, in the sense that it's got a harbour, and then after the harbour you've got a slope going up the hill, and then it goes down the hill, and a lot of homes are perched on the hill. So it's a country of unimaginable beauty, and that beach you see on the top right is like a hour-and-a-half boat ride from the centre of Auckland. It's absolutely stunning, and it's a great place to train. So if any of you are thinking of having a different style of training in a different kind of environment, it's an excellent place to go and study and to train. It was also the place where I first presented the findings of this initial study. And I don't know if I told Dr. Chapman or not, but the first time I looked up the studies for this paper, Washington State kept coming up in the papers. They were kind of mainly large retrospective studies, and that was going to be the basis for my comparison between the outcomes I had and this other study. And about an hour before my talk, I looked to see who the guest speaker was, and it said Dr. Jens Chapman, Seattle. And I thought, oh, that's fine, he's from Seattle, he's not from Washington. And I suddenly realized about 5 minutes beforehand that it was that it was Washington State, and I thought this kind of cold white feeling came over my whole body that I was about to say something that was going to be very unpopular, but obviously not. So it is called the ACC, the Accident Compensation System. Everything in New Zealand has a Maori name, and I'm not even going to attempt to say that thing underneath. But everything has a Maori name. And at the time, obviously, it was very controversial. So a guy called Woodhouse in about the 1960s, mid-60s, 67, spent about 2 or 3 years looking into how they could improve their system. And the problems were the problems that we're facing now. There was too much money involved. There's too much of an adversarial litigation system. So they brought in this ACC as a trial, and it was very controversial. And many people thought it was going to fail pretty soon. So 1974, essentially, components, universal, so in everyone, it's no fault. And importantly, it removes the right to sue for personal injury. There is a big emphasis, and the more I look into compensation, the more I realize that the emphasis is on prevention. A common factor of anyone who had decent outcomes following lumbar fusion had prevention as one of their key priorities. Treatment, obviously, we're all doing that. Rehabilitation, program rehabilitation with a defined process. Unless you're completely disabled, you're going back to work. And if you can't go back to your job, you've got to go to a new job, and we'll find you one. So it covers work and accidental injury. You see a picture of a surgeon there. So anyone guess how much a spinal surgeon in New Zealand pays for their indemnity every year? At a guess?
100,000.
100,000? It's about 100,000 cents. They pay about $800 a year because you can't sue your surgeon if something goes wrong. You can't sue him. So you're thinking, that doesn't sound right. Where, how does that happen? That someone can do something to you and do anything to him. So what happens is you get compensated. You get compensated for whatever happens to you. But the difference is it's not linked to you suing the surgeon. You do not get more money if he is found guilty. You get the same money whether he's guilty or not, no matter what he's done. That is kept separately. He still has to go through a disciplinary hearing. He still has to go through his medical counsel. He may get struck off, but that's not linked to your compensation. And that's all state covered. So very good if you're a New Zealand spine surgeon. Your indemnity is really next to nothing. So where do they get the funding from? So the main areas, treatment injury is what I just talked about. Motor vehicle, obviously. There are those that are working and are off work. There are those that are not working. And there are those that are work-related injuries. So they all come from different areas, whether it's fuel tax or your income tax or your employer. And that's basically how they get the money for it. And like I said, really, can that happen? Can you have, can your employer give you a construction site like that, you fall and actually sue them? It does happen, but the difference is you still get compensated, but it doesn't depend on you suing the other guy. He still has to go through his hearing. He still has to go through every bit of the law that governs work safety, but it's just not linked to you suing him. It removes that right. Who's happy? Most people. Who's unhappy? Lawyers. Yeah. So in looking at all of this, the people I've seen that have lost out from this are the legal profession, and other than that, I can't see a disadvantage to it. So you look at this. Countries that separate compensation and disparate systems tend to promote error reporting and facilitate learning for prevention. So what they're saying is that if you're always trying to be defensive, you're never going to try and focus on what's gone wrong and how you can prevent it next time. And learning from your errors. I mean, if you're constantly trying to cover up or trying to prove that you're not guilty or show that you've not done anything wrong, the theory is that you'll never learn from your errors. And actually this came from a medical liability committee at the AAOS. So look at this. Envy of the world, the Swedish Hip Registry. Both Denmark and Sweden separate the compensation and disparate systems, which facilitates reporting and data. That's how they started this. They removed the fault from the patient suing the doctor. And so they were able to collect all this data. Massive database and used for all number of different studies now. We know that in the US, defensive medicine accounts for about 45 billion a year. And it's tort costs as well, the admin costs. So what's really surprising is this. Even though we're talking about non-adversarial, adversarial, the claims, successful claims per 1 million is 300, 5 times in New Zealand than it is in the US. How can that be? I've just told you, you're not allowed to sue, you're not allowed to, you can't go for your doctor, you can't go for your employer. It's because it doesn't cost anything. And because it doesn't cost anything, you're going to get the compensation you require. Whereas if your admin costs are high, unless you're going to get a whole load of money, you're not going to try and sue them. So that's what happens. You get a small number of lawsuits that have a big amount of money, but not everyone gets compensated. We look at this, professional fees. So I've just taken a couple of states, Wisconsin, New Jersey. That's what happens if you've had a fixed fee. This is an index of how much people pay for their professional fees, 2002 to 2011. Some states have kept a fixed fee, and that's what's happened to those that haven't. And this really mirrors a couple of things for me. One, the number of claims that people have per year, and secondly, the amount of lumbar fusions that we're doing per year. It has risen astronomically, and I remember reading one paper from Utah saying that in a 5-year period, their lumbar fusion rate increased by 174%. So we're dealing with two very big things. So the economic impact is quite great. And actually, if you look at the definition of workers' compensation, it does say that workers' compensation means that there is mandatory relinquishment of the employer's right to sue. That's actually in its definition. So when I was looking at this study, I saw this study from Alberta and Edmonton, where they changed their compensation system very transiently from one that was adversarial and was taught to one that was no fault. So they looked at whiplash injuries. And over that period, they saw their claims decrease from 417 over 100,000 down to 296 in a very short period of time. The time to closure for the claims, 433 days. That's, like a year and a half, down to 194 days. Haven't they got it now? Well, the legal system, the lawyers kicked in and a whole load of fuss began, and they went back to their normal system. So that's where my idea from this came. So why does it, we talk about adversarial systems. I don't know if you get this here. No win, no fee, that's all over the UK. So you can go to your lawyer or your attorney and you can say, I want to sue my employer, and if it's no win, no fee, you don't have to pay them a thing unless you win. So obviously that's just great, isn't it? You just think, right, we're going for it. We're going to sue them. And you've got to prove that you're disabled. So your expectation is going to be negative, and the tendency obviously is to report negatively. And those have all been associated with poor outcomes following lumbar fusion. So you need to prove your disability. And we all know there are numerous studies in the literature showing that psychosocial factors are linked to poor outcomes following lumbar fusion, and they're linked to workers' compensation patients. And in fact, this idea of no fault goes back a long way. It was first in Germany in 1894. Prince Otto von Bismarck, he first put down that if you are disabled from work, you get paid for 13 weeks, and unless you're completely disabled, you have to go back to work. If you are, you get 60%, 67% after. Genius. Everyone followed. Austria, Norway, Finland, UK, USA, everyone followed after that. And that's actually where it began about 130 years ago. So what I'm looking at is the effect of the type of compensation system. And like I said, the first study I saw was this one. And it had a clear conclusion. Legal, work-related, psychological factors predicted worse disability. And there was another study from Washington State to the same effect. And this is where my interest came. And then you look further in the literature, and you realize it's not just lumbar fusion. It is all non-orthopedic operations, general surgical operations, spinal operations, non-fusion. So carpal tunnel, I guess if you're drilling, you're a manual laborer, you're going to get carpal tunnel. If you don't want to go back to work, you're never going to prove that you're better. Knee replacement, surprising. Anything that involves walking up and down stairs, anything that involves manual labor, they don't want to prove that that they're better. Inguinal hernia repair, and at first that was surprising. I thought, no, actually everyone gets groin pain, groin injuries. And of course there was lumbar discectomy and also anterior neck procedures. So let's look at this study. That's a big background behind the thought process of looking into this. So systematic review of the literature, looking at functional outcomes, so not return to work. And the reason was there was enough in the literature to convince me that the return to work cannot guarantee to be positively associated with functional outcomes. So let's just look at functional outcomes, which is a bit of a disappointment because the really big studies from Utah, here in Washington State, and some in Canada, which went into the thousands, were on return to work. So I excluded those from this particular study. And then I looked at the functional outcomes in lumbar spinal fusion under the compensation system in New Zealand. So essentially, we're comparing the effect of the type of compensation system on lumbar spinal fusion. So first part, went to Medline, M-based standard kind of search engines, nothing from the Cochrane control trials register. Compensation and lumbar fusion, kept it very simple. Like I said, we particularly want to look at outcome measures. There are two other things I really want to look at which were unsuccessful because they didn't give it to me. First was follow-up rate. So I put a target of about 75 to 80% follow-up rate. Now, of all the studies I saw, only two actually mentioned their follow-up rate, so I had to exclude that. And the other thing was, you realize with studies, and I was looking all around the world, they're going to have a whole bunch of functional outcomes. correlate them. So I turned to the MCID, the minimum clinically important difference. I thought, I'm going to look at the percentage that reach that target. But one big problem, you need all the data for that. And that was not possible. There was only one study, which I'll come to, which actually gave me all the data that I needed to calculate that. So about 150 studies came up, and that's, for anyone who thinks about doing a systematic review or meta-analysis, get someone else to help you. It's a big load of work. It's the last time I do one of those on my own. And 25 showed specifically outcomes in lumbar spinal fusion, and 14 had functional outcomes with a follow-up that was more than 2 years. So I was down to 14. And there was a whole, like we expected, there was a whole variety of outcome measures. So first of all, unsurprisingly, most of them came from the States. So if we look at these studies here, all but one showed poor results in workers' compensation patients. There were a variety of operations, so ALIFs, 360-degree fusion. For those that don't know, ALIF is an anterior lumbar procedure. Operations that involve front and back, involved the back only, involved cages, no cages. There was the whole lot. So there was no separation from the type of operation. Only Texas actually came out with good results. And again, when you read their paper, it was about prevention. It was about rehab. Carrion's study, her study had the biggest, 783, and yet she actually had the poorest results. And I'll come back to that in a second. So interestingly, if you look at, I pulled this out from the Washington Labor and Industry website. And I wasn't actually looking because to try and show anything about Washington. I was looking to see why Texas did okay. And it did it okay in a couple of papers. Interestingly here, compensation per $100 that goes out. And Texas was right down here. And that interested me. Now there's a few things about this. It doesn't include all your admin costs. And I realized that Washington State has very low admin costs. So if you actually add that into all of this, it goes down a bit. So that wasn't the point. The point was to look at this and correlate it to being the only study in the whole of the United States that's ever been published with reasonable outcomes in lumbar fusion for workers' compensation. And actually, if you look into Texas history, they've actually got a history of being slightly different when it comes to compensation. And there's a Workers' Compensation Research Institute which states this, that since they've actually changed their guidelines, they've seen a positive effect. And the Texas Supreme Court has been limiting employer duties and weakening the ability of injured employers to pursue remedies. That was very interesting to me, because in a write-up of all the compensations and systems in the world, Texas got by far the biggest of any country in terms of what it's done, apart from New Zealand. So that was interesting to me, that was the only positive paper. So we look at the results for the rest of the world. Again, so we've got every continent. We've got Australia, we've got Canada as well, UK, South Korea. Again, Greenoff's paper here, he's a professor in Middlesbrough in the UK. He looked at ALIFs, 360-degree fusions, PLIFs. So every kind of approach to the lumbar spine. Fraser's paper, in fact, Greenoff worked with Fraser. Fraser is from Australia, and he, if you don't know, he sort of devised the low back outcome score. And his was the only study. So they saw an adverse effect at 2 years with workers' compensation patients, but it dissipated over time. So after 10 years, there was still a difference, but it wasn't significant. So that was the only slight outlier. So then you try and look for reasons, and you're looking through the literature. And I don't know if you know, Victoria is a state in Australia. It's down here somewhere. And they have this program, and then they have a similar kind of program in different states in Australia, where prevention of workplace injuries and programmed return to work was a big emphasis in Australia. And the insurance was low cost. So it's not a perfect system, but it's a very targeted system. And hence why maybe their results aren't quite as bad as some of the others. Next slide. So, part 2. New Zealand ACC, which is compensation, and non-ACC, which is non-compensation. So this study was prospective. It's put on a database of 390 patients, so 47%, so a pretty good compensation and non-compensation mix. We looked at the low back outcome score, Roland Morris, and the SF-12. You're probably wondering why people who have compensation have degenerative conditions. Like, those are the 3 main diagnostic conditions. Simply because it doesn't, I mean, just because you have an injury at work doesn't mean you have a pre-existing injury. So this is the thing, you may have degenerative, a degenerative spine, but it doesn't mean this can't be exacerbated by an injury. And this is the big thing, because initially the ACC, if you had a degenerate disc or you showed any sign of wear and tear in the spine, you didn't get anything. And then they obviously changed that because they realized that you could get an exacerbation. So this is the big change. Those on compensation average about 53 years, which is not surprisingly, it's younger than those that weren't on compensation, obviously, because they're working age. So let's look at the low back outcome scores. So the ACC patients are in the redder color, the compensation patients, non-ACC in the blue. So a lower low back outcome score, i.e. worse. You'd expect that. They've been injured at work. No matter how good you are as a person or where you're like, been injured at work and your back hurts, you're not going to say, very few people will go there and say, hey, it's fine, I'm okay, it hurts, but I'm going to go back to work, it's fine. They are worse preoperatively. Worse. So they haven't really got over that that mindset, that phase. Now, our theory is that over time, the effect of the compensation system, no fault, no blame, program rehabilitation, a definite endpoint where you go back to work. And over time, there's no significant difference. This is 390 patients who underwent lumbar fusion. Okay, let's look at the Roland Morris score. So the red again is compensation patients. So Roland Morris higher is worse. So again, preoperatively, they're worse. That's what you'd probably expect. Now, it's surprising, isn't it, in a way, because I mentioned that the compensation patients are younger. So you'd probably expect that preoperatively and postoperatively, they would be better off because they're younger. But they're not. They've been injured at work, they've had an accident, they're not. But over the long term, again, when the system kicks in, no significant difference. A second functional outcome measure at an average of 10.5 years up to 14 years follow-up. No significant difference. And the last one, we didn't calculate SF-12 from the beginning because it wasn't recorded from the beginning, but we thought we'd look at the physical mental scores at 10.5 years. Again, no significant difference. So we've got 3 outcome scores with up to 14-year follow-up in nearly 400 patients where there is no significant difference in the outcome between a compensation patient and a non-compensation patient. And we actually looked at, although this isn't part of this study, we actually looked at, started phoning people around. This is still ongoing because we're trying to link it to some of the return to work studies. And we ran around to find out who had gone back to work. And we picked 1 year, and that was 2 years ago. So there'd be 2 years post-surgery, and phoned around. We've got through about 100 people so far. The current fellow who's out in New Zealand. And so far, about 84% of them have gone back to work 2 years following lumbar fusion. Now, if you look at the results, which I'll come to later in the literature, there's nowhere near anything like that. So I come back onto the MCID. Now, Carrion was the only, this is what I was going to base my whole study on, was MCID, because I thought, if I can show the percentage of people that meet this MCID compared to ours, then bingo. We're comparing all these different functional outcome measures in a set way. Actually, Karen wrote a number of papers about MCID, so that's why she published it, I presume. Staggering difference. 18% reached their MCID, and I used her own markers. 84%. Work that up. what I couldn't work out was why her non-compensation patients only achieved 36%. I have no answer to that. I really don't know. But those are that was the only time I could compare the percentage of patients that reached their MCID. So that was the main part of the study. Now, just to add a little bit onto what's going on now, we've mentioned this paper. So 67% was worse, 68% were worse, and 56% were no better after surgery. I think we all know about that. But it's not just confined to here. This is a study of 725 patients in 2 centers, mainly based at Nashville. And look at this. So there were 725 controls as well. So 26% had returned to work after 2 years. So this is why I specifically mentioned the 2 years. We had 84, 26, that's nearly operation rate 27%. Now you wouldn't do a lumbar fusion if you knew that more than a quarter of your patients were going to come back for surgery again. You definitely wouldn't do that. And total number of days off work was more prolonged. So 1140, that's like 2.5 years or more, nearly 3 years, compared to under a year. So, you know, their conclusion was quite clear. This is another one from Quebec in Canada. So again, very similar results. They're all reporting, all the compensation studies are reporting around 67 to 71% had not returned to work at a 2 to 4 year period. That's pretty consistent. I've only put 3 studies, but there's could put up another 10 on that. But they all report similar things, 67 to 71. So 2/3 of people do not go to work over a 2 to 4 year period. And in fact, that was just on people who had single operations. What I didn't mention was that I excluded revision operations in my study, and actually that was a mistake. If you look at the results, and then for revision operations, multiple groups, the results are even more. 5% of people who have multiple operations don't go back. And I excluded it from my study because I just wanted to do primary operations, not complicate it with, because you could have put a couple of screws in wrong or something. I just did primary operations. So in fact, the results for revision operations are considerably worse. So what can we conclude from this? So the systematic review, I think we can say quite clearly that the adversarial compensation systems are associated with worse outcomes. And we've shown a gradation. So you compare it to New Zealand, and then you compare it to, say, a system in Australia, and even look within the States in a system like Texas that's kind of singled itself out in the history of compensation in the US in having slightly better results. So in New Zealand, there was no significant difference. This is what you want. Everything you do has got to be about long-term follow-up. There is no significant difference between the compensation and non-compensation patients in the 400 patients we looked at long-term follow-up, up to 14 years, average of 10 years. And in fact, the compensation patients in New Zealand, I couldn't actually find any outcomes in the non-compensation population in the world at 10 years that were better than that. So they did as well as anybody else in the long term. So big question, can you achieve good outcomes in lumbar fusion under a workers' compensation system? I would say absolutely yes. But the key is, number one, the money is in prevention, the money is in the rehab, the money is in a controlled and defined return to work. And if you're not, then you're reassessed and things get a bit tougher. Really, it's the multidisciplinary rehab program that's the key to this. And that was really what I got out of this. It wasn't one thing, no fault, non-adversarial, non-tort system. It was a number of factors that all had to be in place. And that's why some systems are relatively good, some systems are terrible, and one particular system is really good. So as I contemplated, I left New Zealand and I had a long journey back. It's about 30 hours on the plane. I look back, and that's Rangitoto. It's the volcano that protects Auckland. It means red fire in Maori because it erupted once. And I thought about it, and I got back to Heathrow, and the irony of this was not lost on me. So I was queuing up to guys. If those of you've been to Heathrow, it's all about losing your luggage and and queuing up for hours. So as I was queuing up for hours, I saw two signs that looked something like this. You know, straight away, you know, you come across the other side of the world, you don't even have to go to the other side of the world. Completely different thought process. So in a smaller country, you can, I think, control the factors that are trying to work against you, and mainly the legal profession. They controlled it in New Zealand. How do you control in a country like the UK or Canada or even the US? US, you've got state-run systems, so you've got some kind of autonomy at that level. But the irony of it was not lost on me, and I went back to the bright lights of London. And as far as my life was concerned, there was big change afoot. That was the old hospital, and pretty soon, just before I arrived, the new hospital opened. And you know, it'd been on the agenda for like 10 years. They've been building it for 8 years. So I was coming back to start a consultant or attending job, and you'd think, wow, this is exciting. You're going to walk into a job. It is exciting, but I guess the thing for me was my predecessors, for one reason or another, resigned, and that's how I got the job. They resigned in the old hospital, and they moved to the new hospital. Some things were shipped over, most things weren't, and it took them a while to find a spine surgeons in the UK are in demand, unlike hip and knee. So if you're a hip and knee surgeon, there's about 50 people applying for every attending job out there. Spine surgeons, there's still not that many of us, so they couldn't, they waited a while to build up some momentum to attract people, and I came to a department that was literally empty. So I had no clinics, no MDTs, no theatres. I didn't have a full set of instruments. I didn't even have a table. So you're probably wondering why I'm putting up a picture of breakfast here, because this reminds me of my first day. I don't know what most of you think your first day as a consultant or attending would be like, but I went to our trauma meeting. My eyes were popping when I saw all the major trauma that had come through in the last 24 hours, because I was different to 6 years ago. Everything's more centralized now, so my eyes just, I couldn't believe the stuff that was coming through the door. And then I went and had breakfast, and I had a coffee, and I pulled out my digital piece of paper and pen, and I started writing. How am I going to build this department? Good place to start is your clinic. You've got to have a clinic, so I didn't have one. Build up your MDTs. Now, GP is a primary care doctor. They were all pissed off as hell with the spine surgeons, because they had built up a waiting list, and then they disappeared. So I had to let them know. I had to go around every surgery letting them know that I actually existed, we existed. And then we had to get the equipment, so like the tables, the instruments. We're about to change our microscopes and get your service running. I've now got the TB service running again, or I've taken it back 4 months ago. We do about a TB spine clinic once a month. I get about 3 TB referrals a week. Most of them don't get operated on. We've started our deformity now, and we've got an agreement for regional meetings, and my colleagues, I have to attribute this to them, have got a training simulator in. So this is all in the last 7 months. But our drive now, and this is our big focus, is our research. And fortunately, all the tides were going with us at this point. New hospital, everyone's in a better mood and a little more positive. And we had a merger of what we call our academic health science centres. So those are the research centres linked to hospitals. So 3 of them merged into one. They're linked to our hospital, and we've now got the biggest in the UK with a lot more capacity for research. And again, much like London, much like the hospital I work in, it's the old and the new. This is the old system which is still used, the old building which is still used for admin, and that's our kind of virtual new medical school and health science centre. And this is really our dream now, to build from nothing to something quite big. And we've got quite a lot of ambition to build our department and all our research based around everything that we've done so far. And it's really something that has driven us now to reach out and to learn from people around the world. And the first person I emailed was Dr. Chapman, to come and get ideas, to collaborate, and to really build ourselves up over the years that come. And I thank you very much for inviting me to come. Thanks.
So I think, first of all, thank you. It sometimes takes a world traveler from far away to show us what we're doing here, and it's particularly meaningful, and I'm glad that our state was also recognized in your assessments. A couple of questions, I'm sure, from the audience. I'll start off with one. In most states in this union that I've been in, Workmans Compensation patients, or L&I as they're called here, evoke a negative response in doctors. They actually don't want to take care of them. Whether they're surgeons or physicians, it doesn't matter. It usually evokes a negative connotation. Is an ACC patient, or does an ACC patient in New Zealand evoke a similar kind of a negative response, or are doctors really just equivocal, just like your results showed?
So I guess there's two factors. The kind of more cynical thing to say is that they all go privately. They don't go on the public system, so any ACC patient can go on the private system, so they very rarely get a no. And second thing is, because of the actual system, very few of them, and because most of them know that their results are actually fairly equivalent over the long term, it doesn't come into the picture. It doesn't really feature. I think it's more the other factors, like the single factors like anxiety. If you know someone's got a history of depression, anxiety, or and the other comorbid factors like diabetes, smoking, those things come into it more. But in terms of compensation, that doesn't really feature.
Is the evidentiary or documentary burden on the physicians or the medical system equal also, or is there a higher evidentiary burden?
As in, are there more compensation?
Do you have to do more paperwork? Let's put it this way, or documentation work for an ACC patient?
No. So the patient has to do a lot of paperwork. There is a lot of paperwork anyway, because if you fall over and break your ankle, you've got to fill out all the ACC documentation. So even if you break your wrist or whatever like that, so everyone has to fill it out. So unless you're an elective patient with a pure degenerative condition, most people have to fill out this ACC paperwork.
Great. Fantastic talk. Questions? Dr. Loja, why am I not surprised?
I was in New Zealand for a while in 1989. The ACC system was going bankrupt. At that time, any injury, whether on the job or not, was covered by the ACC system. So people would be out playing rugby and get themselves a broken arm, and they were covered. And in that era, literally the system was going bankrupt. And so New Zealand dramatically changed the ACC system to be only injuries on the job. New Zealand is a very different place from the UK or the United States. It was founded by burned out socialists in the early 1900s who emigrated to New Zealand, and it shows. And I think it may not be safe to assume that the only difference is the compensation system, when the whole tenor of the country and the way of life and the way people think and act fits the compensation system, but correlation and causation are not necessarily the same thing. And I think you need to be careful about saying, well, it's the compensation system that does it, when I think there's a whole culture that's quite different.
Yeah, I mean, I said that I can only publish the results I've got. I mean, I even looked online to see if there was an index as to how hard each nation was in terms of their resistance to pain. Everyone says the Kiwis are very stoical. If you say to a Kiwi, okay, so you're going to have a lumbar fusion and I'm going to put a cage in. I was thinking about doing iliac crest graft, but it's going to give you a scar there and it's going to cause you some discomfort afterwards. But I believe that you might get a better fusion. Also, we'll do the iliac crest graft. They don't care about an incision. They don't care about any pain afterwards. They're very stoical people. They're historically farmers. You just can't prove things like that. And it is about culture. So like we have the National Health Service, and it is inbuilt in people's mindset that healthcare should be free. You should not have to pay for your healthcare unless you want to, or you've got insurance through your work, or you choose to have insurance. So yeah, it's a whole cultural thing. That goes over generations. But the point I was making was that they were very resistant to it when it first started in 1974. And it's evolved over time as well. So for instance, there are a lot of New Zealand physios in London, and when you meet them, you say, oh, you know, how come you've come here? New Zealand's so beautiful. And they said, well, I had a great business in New Zealand until the 90s, because you know, basically they were getting all their patients indefinitely, and ACC was paying for them. And then ACC said, nope, you're having this amount of sessions and you're going back to work. And all the physios went bankrupt, and that's when the financial, when ACC's financial situation changed. And they vary. They, you know, like 2011 they made a profit. Last year I hear they made a bit of a loss, but they're coping.
Any other questions? So each healthcare system more or less deserves what the people's expectations are. What about Denmark and Sweden? What are their return to work rates after spine fusions? You mentioned those two as having a no-fault system as well. So what do the comparison studies show there?
So Sweden is terrible, actually. So you probably know that. That's why you're asking.
We had Peter Fritzell here, and he was hoarsely whispering that same statement.
So I don't know how to pronounce his name. Nachemson. Yeah. So he's published quite a bit on lumbar fusion and of it for quite some time, because I believe that Sweden has 95%. Well, they certainly did for their lifetime if you're injured at work, and so their outcomes from, in fact, I know I mentioned the Hip Registry, but their outcomes from lumbar fusion were terrible, and certainly those reported by Nachemson. So Denmark, I'm not sure actually. I didn't look at that. Yeah.
State of Washington produces 1,000 lawyers a year and 200 doctors. How did they suppress the legal profession to get this legislation on?
Well, actually, you know, it was at a time when the links between the UK and New Zealand were very strong, and they still are quite strong. And a lot of people used to disappear to the UK for work anyway. And I hear at that point in the 70s, and when this took over, all the lawyers were basically shipping out to London, and in fact they still do. And so they tried to fight it, but you know, they didn't get very far because the government behind them, and then a whole drove of them left. They decided that in those days it was like cool and trendy to go to London. Those days are kind of gone, I think.
Can
But
the British absorb any more lawyers?
you need money in your economy to have more lawyers, so I don't think so. They seem pretty. I think this generation. This is the thing. It's the generation change now. So 74 was the last generation that got over that big hurdle, and now the current generation. If you're going to be a lawyer, you're going to be quite limited, and you're going to get the salary of a teacher probably.
So let me ask you one other question that's kind of really early recognition of at-risk patients in terms of, we're not talking about a major or structural problem. Patients who have pain, who are at risk for failure, seems to be probably very, very important.
Yeah.
So the depressed patients with a significant distress score or something like that.
Yeah.
Is there a system in place that recognizes those patients through scoring systems or anything like that? Or does the system have such a structured care plan that by about 6 weeks or a specific tide mark, they then raise a red flag and get escalated out? So how does that work, that early recognition in New Zealand?
In New Zealand?
Yeah.
They don't actually, they don't screen for Zoom depression or anything like that. No, they don't actually do that on the ACC. I think there are individual surgeons that do that, like the Zoom depression score, but there isn't, they all have a psychological input, but they aren't, their outcomes aren't measured in terms of psychosocial factors formally.
So is the structured care plan then that escalates patients out of the normal pathway?
They have a psychologist, and that's about it. And maybe that's a slightly cultural thing, because Kiwis don't report when they're upset. They don't report when they're depressed. They don't go to a psychologist. That's a sign of weakness. So they don't have a formal kind of process, other than if they think that a very kind of gross system where if they think there's a psychological involvement, which there normally is, they go through go to the psychologist, and they go through a kind of a cognitive behavioral therapy.
Great. Oh, one more. Joe?
Question. You mentioned multidisciplinary rehab as an important factor, but this is, you're talking in this case about rehab after surgery.
Yeah, yeah.
And why would that be very different from sort of rehab that patients would have in Quebec or Washington State? Or, what was different in the rehab?
Well, I think patients that were, I think it was targeted and defined. So those that were compensation patients, I think if you're a non-compensation patient, you go through a normal rehab process. But I think the fact that the compensation patients didn't have a defined endpoint to their rehab, and also I think before at that time in New Zealand they didn't have a program, rehab program. So they got a rehab program, and then they changed it and they made it defined. So each week, these are your goals, and that's when you're going back to work. And if you're not going back to work at that time, unless you can prove a complete disability, your compensation goes down. So they know that basically they've got, and I've met a few of them, I got to know one or two people on the system, they knew that date was coming. And unless you can really prove a disability, then you had to fit into that date. Otherwise your percentage compensation of your salary goes right down, and it comes down to virtually nothing. A bit cruel, but it worked.
One more question, Stan?
It is a bit cruel. If you have no method to select high-risk patients pre-operatively, and then we do something to them and their outcome is poor, and then we have a hard stop date for their disability, patient satisfaction, is there any remediation to those patients, or is that policy that they have no option after this?
No, Dr. Chapman asked about the state, whether they had a program for assessing psychosocial. They don't, but then if they're going to have an operation, they go to the individual surgeon. So they have, once they've decided, okay, this patient is on ACC, the compensation, he might need surgery, go and see your surgeon. And then from then on, you're just going through a normal process. So you come to the clinic, you fill out, you go on the iPad and fill out the outcome measures or fill it out. So the individual surgeon still has his, his way of doing it. So if he decides, he doesn't have to operate. If he decides, oh, you need, a program rehab, or you need a pain clinic or whatever, then he can do that. And then you go through their normal process. But the state itself doesn't have formal set outcomes that it takes for psychosocial factors. They hand it over to the surgeon, and then they do their own practice that most of us do in assessing patients preoperatively and what they need.
Right, so I understand you though, still,
Yeah.
the decision, it's about you have a relationship, you get a procedure done, surgical or non-size, and if the outcome's poor, for whatever reason, poor functional outcome, there's still a hard stop date, right? And there's no remediation.
No, you can. I mean, it's not set. I mean, they'll assess your disability, and they will find you something else that you can do if you can't do that
Right,
job.
that's a critical part of this conversation. There's some sort of strategy.
Yeah.
To reorient. It's not just you're done, see you. There's
Oh no. It's all about, and they will look for you. They'll look around and say, okay, based on this assessment, I think you can do these jobs, and we've looked, and there are systems. These jobs are available. So you're kind of stuck, in a way.
Well, you've certainly given us a lot of food for thought, and it's nice glimpses. Thank you so much. Great talk. Fantastic.